Good evening and a warm welcome to our weekly webinar series on emergency medicine, where we bring forth interesting, relevant, and up-to-date topics in emergency medicine presented by our experts. As we know, today's topic is both timely and essential, and we are privileged to have an expert who brings deep experience and insight to our discussion. Before we begin, I'd like to thank our organizing team, organizing chairperson, Dr. T.S. Srinath Kumar, HOD Group, HOD and Group Head Emergency Medicine of Yashoda Hospitals, Dr. Sri Saujanya Ma'am, HOD Emergency Medicine, Yashoda Hospital, SciTech City, National President of Society for Emergency Medicine, India. Without further delay, let's get started. Please join me in welcoming our speaker for today's session, Dr. Sharat Chandra Uppaluri, who will be talking to us on the topic of pitfalls in geriatric trauma. Dr. Sharat Chandra, small introduction to Dr. Sharat Chandra Uppaluri, sir. He is a MD Emergency Medicine from Nizam's Institute of Medical Sciences from the year 2022. And also he's been awarded the President's Gold Medal in DNB Emergency Medicine in 2024 and has recently finished his MRChem certification in 2025. Over to you, sir.
Thank you so much, Dr. Pranay, and thanks everyone for organizing this. It's my first time presenting in this platform, and I hope this won't be the last. So I welcome you all again, and let's go into the topic. I won't take much of your time. So the topic for today will be pitfalls in geriatric trauma. Okay, so we'll stick specifically to the topic because geriatric trauma, if I have to cover it entirely, it's going to take me 2 hours. So what I want you guys to understand, whoever is joining live here, is that how is it different from a normal trauma? How is it different? What discrepancies exist when you're dealing with an elderly patient as compared to that of a normal patient, normal adult? Okay, so if you understand this, the algorithms of treatment, the concepts of treatment will still remain the same. So my aim in choosing this topic is to give you that insight into the elderly physiology, what's happening in their body, how is it different, and what differences that we should keep in our mind before treating them or while treating them. All right, so that's the reason I chose this topic. It's going to be a short and sweet topic, so please feel free to drop in your doubts or queries or whenever you feel like. Okay, let's keep this interactive and let's start. Okay, so let's start with a small case scenario. All right, so we have a 75-year-old man, history of fall in the bathroom. Okay, you can't fall from 6 feet or 10 feet in a bathroom, right? So it's a ground level fall. He was brought in by his son, let's say, and on examination, he was found to have a blood pressure of 100/70. And his GCS was 7 out of 15. And there was a scalp hematoma. This is what the physicians who were treating him initially noticed. And rightfully, a GCS of 7/15 will require an airway protection. So a decision to intubate was made, and what was he given? Routine rapid sequence RSI is rapid sequence intubation, routine RSI doses of etomidated and succinylcholine. After intubation, unfortunately, his blood pressures dropped to 60/40. What do you do then? You go ahead, secure a cannula, grab blood or whatever you want. But before anything could be done, he sustained a cardiac arrest. Did not give much time. All right. So I'm going to stop here and I want you guys to reflect on what went wrong. Okay. I'm going to stop for like 10 to 20 seconds. Just think about it. Okay. What went wrong? I'm going to put the case scenario again. Elderly man, just a ground level fall, probably hit his head, which is why his GCS was lower. BP 170, by definition, normal. Yeah. And there was a scalp hematoma. Nothing much significant. Rightfully, intubation decision was made, drugs were given, but then he collapsed. What do you think went wrong? Just think about it, okay? And keep this in your mind. And if you're thinking the right answers, let's know that in the end, okay? All right. So let's start off with my topic per se. So you will get the answers to it probably in whatever I'm about to cover in the subsequent slides, okay? Number one, okay, we are talking about pitfalls. So first pitfall is under triaging the patient, okay? Remember, ground level falls can produce serious injuries in the elderly. Don't you think so? Because, well, they are weak. as simple as that, and that can generate traumatic brain injuries, significant traumatic brain injuries, like we have seen in this patient. Can be significant pelvic injuries, can be significant cervical injuries, because their bones are weak, their organs are weak. So they don't need a high impact mechanism to cause serious injuries. Yes, because they have osteoporosis and their old age physiology will be different, which we'll see in the coming slides. And fortunately or unfortunately, many of them are either on anticoagulants or some blood thinners, some antiplatelets. So because of all this together, they combine to give out an amplified trauma response. For a simple mechanism, the trauma in them is much higher. Okay. So what you need to remember in this is, we sometimes tend to say it's just a fall or just a ground level fall. But in the elderly patients above 60 years, that's an arbitrary value again. We'll know how we should categorize based on objective science rather than just age, right? So don't just consider this line as, it's just a fall. Nothing serious is going to be there. No, don't do that. Okay. In the elderly, please activate trauma response if at all you have that in your hospitals quite early. Okay. Look at this. For example, this you can see an intertrochanteric fracture here very clearly, isn't it? So this happens with a ground level fall. Have you seen any elderly patients coming with a significant fall or something? They fell from like first floor or second floor and sustained this. No, most of the IT fractures, what happened? They just slip and then they break their bones. Okay, this is one example. And if you can see more into the picture, you can see how the bone density is, right? It's almost translucent. So, which is why they sustain easy injuries at the junctions of the bones and all. And this is one example of how they can sustain a fracture with just simple mechanisms. Yeah, which in normal patient would have required much serious mechanism for this to happen. Right. All right. This is utmost important to any emergency physicians because, or even otherwise, whoever is dealing with trauma as such. So we have airway problems with the elderly because they have decreased protective reflexes. And what can that cause? Immediate aspiration. We have better reflexes. We have better gag reflex. We can just close our glottis and throw out the vomiters or whatever. But elderly patients, because of multitude of problems, they can be having the prior existing neuro disorders. They can be on certain drugs, and they can be demented. Whatever it is, they have consequently reduced protective reflexes and they are more prone for rapid aspiration, right? And then, come on, who doesn't have arthritis? This is happening even in 40 year, 50-year patients these days. So imagine a 60, 70-year-old man coming to you. He or she is bound to have arthritis, and that will limit mobility of your neck. Yes or no? You can't extend the neck well. As such, in trauma, you shouldn't extend the neck. And moreover, if the patient is giving you a bonus of limited neck mobility over that, trust me, it's going to create a havoc while you're managing the airway. All right. And then you have patients of edentulous patients or somebody having loose dentures. So it will interfere with mask seal. Edentulous will interfere with mask seal. Having dentures may interfere with your laryngoscopy. So just keep this in mind. Why am I saying this is keep a low threshold to either intubate a patient or secure an airway in the elderly patients. Okay. Don't think he's going to get better. Okay. Because his physiology will stoop him to deteriorated condition very quickly, even before we anticipate. And we all know airway kills in seconds. Yes. So keep a low threshold to secure an airway in elderly patients. And most important thing people often neglect is in rapid sequence intubation, ATLS advises at least 20 to 40% reduction of routine RSI drugs, okay, to avoid cardiovascular collapse. All right, because they lose fat, they lose muscles, their organs are more prone for severe damage. So they have heightened sensitivity to sedative and paralytic drugs. So if you're using like 0.3 milligrams per kg of etomidate in a routine adult patient, try to reduce it to maybe 0.2 or maybe 1.5 mg per kg. Maybe that is enough for an elderly patient to get induced, right? Same goes with the paralytics. Okay, if the paralytic action is prolonged for longer, you will have difficulty in bringing him out if your airway is failing. Or even after intubation, successful airway, if the paralytic acts for longer, you won't know how to. I mean, you can't assess the patient. Yes, and he'll need more sedative agents to keep his paralysis unknown to him. Yeah. So literature says at least give a 20 to 40% dose reduction to avoid a cardiovascular collapse. And most importantly, we are all, comes airway with C-spine stabilization, and we are enthusiastic to place a cervical spine. But in the elderly, you must use collars judiciously. Why? Just look at this image. This is an elderly man, and let's say he has an arthritis here, as indicated by the image here, right? Now, if you put a collar, see the bones interspersing on each other, and this improper placement will make the damage more in this patient, okay? It just creates more damage. But what you can do otherwise, so these are called poster stabilizers, okay? They just come with cushions on either side, and it just immobilizes. The whole purpose of putting a cervical collar is to what? To immobilize the neck in relation to head and body. Yes, I'll repeat that again. The purpose of putting a cervical collar is to immobilize the neck with respect to head and body. So if you're achieving the same result with such cushions around, so it's even better, right? You don't have to malalign the spine. Instead, you can just use these cushions in the elderly. If you don't have them, you can as well place few NS bottles on either side of the neck and then just abut them to the neck. All we want is to prevent these movements. That's it. However you want to achieve it, it's good, but don't create more harm. All right. So this is my aim of telling in telling that use collars judiciously. Don't just over enthusiastically place it on everyone. It's not required. Okay. Simple immobilizers will be good too. Okay. And this will cause even further immobility, may cause aspiration, interfere with airways. So many other things happen. So just use immobilizers. Okay. The patient will be good. Now coming to the third pitfall. Normal vitals. We've seen this in our case presentation, right? I just want you to keep that in the back of your head. So as we are progressing through our presentation, we'll know what all could have been done in that patient, right? First thing, they have a relative catecholamine insensitivity. What happens when you lose the blood or when you lose fluids? What happens? Body creates a surge of catecholamines that will increase the blood pressure, that will cause tachycardia, thereby increasing cardiac output. But elderly patients, their receptors lose that sensitivity to catecholamines. So what will happen? And compounding onto that, many are on beta blocker usage, right? Hypertensive patients, heart disease patients, whoever they are. Many of them are on beta blockers, right? So both of this together creates a no tachycardia response. So even if the patient is losing blood, he may not put up the tachycardia. Normally in adults, if you see a patient coming after a trauma with a heart rate of, let's say, 130, you would know, right? Like something bad is happening. He's probably losing blood somewhere, or he has lost blood somewhere. But in an elderly man, though he might have lost blood, which we couldn't see, and heart rate is just 78, you may feel happy thinking, okay, yeah, his heart rate is not rising up. But that absence of tachycardia is a response because of these two reasons. There is less catecholamine sensitivity, and the patient probably is on beta blockers. So he's not throwing that tachycardia response for you to cash in, right? And let's say the patient is a known hypertension and his baseline blood pressure itself is 140 over 100, assume. Now, in that patient, if an SBP of 110 is there, will you be happy with that? No, obviously. Isn't it? Because an SBP of 110 may indicate hypotension in a known hypertensive case because we do not know the baseline blood pressure. This is another red flag which may masquerade as normal vital sign, but trust me, it is not. An SBP of 110 or even 100 should be considered hypotension and should prompt us to look for blood loss or volume loss somewhere, right? And shock index. What is shock index? If you can just tell me what is shock index, or if you're thinking shock index is something like heart rate over systolic blood pressure, you're right. So normally less than 0.9 is okay, but in this condition, the threshold is lowered to 0.7 according to recent ATLS guidelines. They say keep a shock index of 0.7 as a threshold. Something more than that, treat it as a shock because their inherent heart rate is lower. And elevated lactates and base deficit lactates, they give a value of 2.4. But then again, this shouldn't be taken as absolute values. Consider this in consideration with the normal, in consideration with the patient's, individualized patient's presentation, right? Don't just take this as absolute values. So we call it occult hypotension or cryptic shock. In other words, shock is existing, but it is not evident to you outside. So it is occult. It is something invisible or cryptic shock, or we call it occult hypotension. So this is quite commonly seen in elderly patients because of all these reasons, right? Fourth pitfall, delayed or missed head injury. Because elderly patients, their brain undergoes atrophy. I mean, that is a normal aging process, isn't it? If the brain doesn't undergo atrophy, the patients will keep living forever. Yeah. So it is bound to undergo atrophy, and then the brain shrinks up. What happens? The skull doesn't shrink, brain inside shrinks up. So the gap between the dura and the arachnoid increases. So what happens? The veins which bridge this gap may, and the veins also are fragile and the length is increased. So any minor head injury, small hit on the head, these veins may give away and create blood accumulation. Yeah. So most commonly we find subdural hemorrhages in elderly patients because this is the reason. Yes. And to add on to that, patients are likely on antiplatelets or anticoagulants owing to their heart disease or vascular disease or prior strokes, whatever it is. So my point in telling this is keep a low threshold to perform a CT head. Okay, the routine CT head rules which you might be using in adults do not apply like in a blanket way to all the elderly patients too. Okay, individualize. If the patient is on antiplatelets or anticoagulants, even a minor fall, small head injury, even if the patient is normal now, okay, you still have to keep a low threshold to go ahead and get a CT head done. Okay, and again keep a low threshold to repeat a scan if the mental status is changing or if you think it is about to change. Okay, repeat a CT scan because the blood takes some time to accumulate, and the effect of antiplatelets or anticoagulants, we have seen many cases, patients present normal, the initial CT head will be normal. And if the patient will probably throw a seizure or his sensorium drops, and then we do the CT scan again after 6 hours or 12 hours, we find a new SDH forming in the brain. It happened quite a lot of times. So keep a low threshold. If you think the patient is about to change or something's about to happen, keep a low threshold to get a CT head or even repeat the CT scan if required, right? And if the patient is on anticoagulants, I don't need to go into details of how to reverse them. Okay, if he's using warfarin, go for vitamin K and PCC prothrombin complex concentrate. If he's using newer anticoagulants, you have antidotes for certain like dabigatran, adarucizumab, andexanet alpha for factor 10 inhibitors like apixaban or rivaroxaban. You have those, all right. If they are not available, then go for prothrombin complex concentrate. If it is still not available, go for FFPs. Okay. Why they did not give FFP that much importance is that the dose of FFP is higher, right? 15 milliliters per kg. Imagine that. Okay, in a 50 kg man, that goes up to beyond 500 or 750 ml, right? And so that much volume may compound a volume overload state in an elderly patient, which is why they are giving importance to four-factor prothrombin complex concentrate rather than FFPs. But if you do not have them, then you have no other option but to give FFPs. All right. So this is actually a real case that came to us. He was a 59-year-old man who was using ecosprin for his prior heart disease. He sustained a ground level fall and hit his head to a bedpost while he was falling down. It was a simple fall. But then 6 hours later, can you see an SDH developing here? Right? A simple fall. But because of the antiplatelet use, the patient has developed a subdural hemorrhage. Right? You can see it more clearly here, and there is some effacement of ventricles, so there is a mass effect. Okay. Luckily, patient did not require a surgery, but then we had a finding. Yeah, we need to anticipate. We knew something was wrong in the brain, so we know what to expect. Okay, so this was actually a real example, and I have multiple CT scans of such patients who come later who have delayed presentations. We even have cases who present 2 to 3 weeks later, and they come with a subacute SDH developing in them. And if we trace back the history, they would have a small trivial fall somewhere 2 to 3 weeks back, right? If they had come earlier, if we had diagnosed earlier, probably we could have anticipated what's about to happen, or maybe even stopped their blood thinners, right? Coming to the next pitfall, over or under resuscitation, right? This is you have a tiny flexibility when it comes to volume or giving fluids in elderly patients. Why? Because they have fixed cardiac output. Unlike us, who can vary, our cardiac output can range from 5 liters per minute to even 25 liters per minute if you are trained to do that. But going to the elderly, they always have fixed cardiac output, and their response to increased cardiac output again is limited by certain drugs like beta blockers or something. Yeah. So they have fixed cardiac output and limited renal reserve. Their GFR comes down. Yeah. So they have limited renal reserve to prevent that loss of fluid also. And elderly patients, they're less sensitive to antidiuretic hormones. Yes or no? So what happens? The response is less, so the kidneys think, okay, I can still filter more urine, and they, upon an already lost fluids, the kidneys may tend to act normally and then lose even more fluids. So they have a limited renal reserve, and if you combine these two, giving too much fluids can cause pulmonary edema. If you give too little, it will cause renal failure and tissue hypoperfusion. Yeah. So trauma guidelines advise that do not give much fluids in them, just go for early blood products, right? And do not use the vital signs as your endpoints of resuscitation. Use patient-tailored objectives like urine output and base deficit, because these vary between patient to patient. There are no generalized normal values. Okay, so use urine output and base deficit to assess your response to resuscitation. How much fluid he needs more, or how much fluid has already been gone? Should I stop my resuscitation? And if you're good with that, use it to bedside 2D echo, and you can screen for blood loss. Yeah, you can check IVC diameter. And there are many other methods to check for fluid responsiveness. So keep this in mind. Keep these two things as a mantra. Too little fluid can cause renal failure, too much fluid can cause pulmonary edema. Tailor it to the patient. Yeah. All right. Most important thing, neglecting pain. I see some of my juniors neglecting pain even in the adults. They give 1 gram of paracetamol in a fracture. Like, come on. Treating pain is absolutely necessary. And if you ask me, it doesn't just soothe the physiology. It is ethical to treat a pain, isn't it? Because that is the only subjective thinking which you cannot properly quantify objectively. It is a completely subjective thing. So please do not neglect pain. And in the elderly, this garners more importance because undertreating pain can cause atelectasis. Let's say patient has rib fractures, you don't treat pain. So what happens? He can't even breathe properly. He doesn't expand his chest. So what happens? The lungs will undergo collapse. He will develop atelectasis, and if there are some lung contusions in there, they're going to get infected. Yes, and that again is a vicious cycle. That again causes more immobility. And not treating pain causes more immobility that can lead to pressure ulcers, bed sores, and so many other things. And not treating pain can land the patient in delirium too. Already demented or delirious patients, if you are not treating pain, that discomfort can push them into, just even if they're hanging at the edge, that will, if you're not treating the pain, that will push them into a delirious state. And it's more difficult to handle a delirious elderly man, trust me. And all the guidelines, even the pain management guidelines, ATLS guidelines, advocate for multimodal analgesia, like not just pharmacological methods. So go ahead and do non-pharmacological methods, like, remove any splints that are still not required. Like if you put a pelvic binder, let's say, for example, once you rule out a pelvic fracture, just remove it immediately. Okay, there's no point in putting it further. So these are all certain things that will soothe the pain non-pharmacologically, along with some pharmacological management. But then again, giving pharmacological management still has its own systemic side effects. And elderly patients who are already bleeding, you cannot give NSAIDs. It will cause either gastritis or they have some bleeding manifestations, their kidneys are gone. So NSAIDs are not that good to go, unlike in younger patients. So we have opioids and acetaminophen. Opioids, again, they come with the side effects of nausea, bowel immobility, and sedation, most importantly. Yeah. So I love giving regional blocks and nerve blocks, and I think every emergency physician should be, at least they should know the basics of nerve blocks, and then just go through nerve blocks and give nerve blocks whenever possible, be it intercostal blocks, be it hematoma blocks, be it facial blocks, whatever it is, okay? Because they don't require, they avoid the need for a systemic pharmacological method and disposing the patient to side effects again. Just give nerve blocks. Unless your technique is horrible, Rarely the patient lands up with systemic toxicity of local anesthesia, okay, LAST. But if your technique is good, if you just block the nerve, trust me, it relieves the pain immediately and the patients are comfortable, okay? But comes with a caveat, which is check for the sensations before and after giving the nerve blocks, both vascular status and sensations before and after giving the nerve blocks, okay? If you follow these precautions, giving nerve blocks comes under multimodal analgesia and they work the best for elderly people, okay? All right. Yeah, elderly patients are too cool, aren't they? If you like sit and talk with a grandma, trust me, it is the cutest thing you will ever find. They keep on talking and it's nice to interact with them. But it is a fun, they are too cool in the sense that their skin loses elasticity and subcutaneous fat. And they also lose lean muscle. What happens because of these two? They're easily prone for hypothermia. And what does hypothermia cause? The cascade of lethal triad, yeah? Acidosis, coagulopathy, and then hypothermia. What happens? There is no skin elasticity, no subcutaneous fat, so the heat won't retain inside, and lean muscle loss will not trigger thermogenesis. So if muscles are less, contractions are less, thermogenesis is less. So all these three combined, they cause hypothermia quite easily. Okay. So what should you do for this? Give warm fluids right from the start. Use warm fluids and warm blood products. Okay. Do not give that cold blood products. In emergency, if the patient is losing blood, sometimes we tend to put cold blood also just to sustain their hemodynamics. But in elderly, please keep in mind, please keep this extra thing available with you, radiant warmers or some kind of blood warmers with you so that you can give warm fluids and warm blood products right from the start. And because of loss of skin elasticity, subcutaneous fat, you must try to pad bony points like elbows, okay, like your ischial tuberosities, your back, your scapulas, shoulders. It's better to pad these bony points so that they don't develop pressure ulcers. And also, if they're on stretchers or trolleys, again, these bony points are another way to lose the heat. Yeah. And if necessary, use extra sheets and blankets. Okay. Your comfort, or if the AC is too much, turn it off. ADLS says your comfort takes the least priority, patient's comfort takes the precedence. Yes, sir. I mean, I totally agree with that. Even if you're sweating, it's okay, but the patient should not feel cold. Period. Yes. So use extra sheets and do all the methods required and just make sure they don't land up in hypothermia. So keep monitoring their temperatures frequently. Okay, I think this is one of the most important slides in my presentation. So I request your utmost attention. Frailty. Okay, frailty is nothing but the status, the physiological status where the elderly patient's body doesn't respond usually as it must to any physical or physiological stress. The normal response is not adequate. Okay. This is the entire crux of frailty. Okay. We call them frail old gentlemen or frail old lady. Okay. When I say frailty, it's actually a medical term, which means their physiological response is not as adequate as it should have been in normal people. Yes. So, because of frailty, there is also delayed definitive care. Why? So before going into that, let's look at frailty. It essentially means there is not much physiological reserve, and that predisposes the patient to a high risk traumatic event. Yeah. So there is a risk score advocated by ATLS even before it used to exist, and then it's just been reiterated in the recent updates as well. So there is something called trauma specific frailty index, and more than 0.25 is frail. Let's just look at that. Okay. So it has like I'm not going to much details of it because if you just type this in Google, you'll still get it. Okay. It's easily available resource online, and trust me, it's not up to us to remember everything. It has like 1, 2, 3, 4, 5 components, and it has 15 variables in total. Yeah, if you just count this, 3 here, 5 here, 5 here, and 1 and 1 and 1. Okay. So it has like 15 components. I mean 15 variables and 5 components. Right. So it talks about comorbidities and there is a scoring. And it talks about what the daily activities are, and it has a list where you just have to hit the yes or no. And if he needs help with walking, and what is the attitude with help, because this gives you an indication towards elderly depression or elderly dementia. Yes. So a demented patient will have higher mortality than a normal patient, which is why they have included the health attitude and mental status of the patient also in the frailty score, right? And how functional he is. And surprisingly, their measure of function is only sexual activity. I think if you're active sexually, they assume that you should be active otherwise also. Like your routines, yes, if you're sexually active, you are bound to take care of your routine activities, isn't it? Maybe that's why they included the sexual activity in this. That's the only activity in the functional status of the patient that's been included here, right? And nutritional status is given out by an objective measurement, which is albumin. Okay, and if you combine all the scores, and if it is more than 0.25, it is considered frail. Now, if you look at it, a positivity in any score, let it be cancer history, coronary artery, PCA, whatever it is, even mild dementia, this is a printing mistake in ATLS. It is not milk dementia, it is mild dementia. Nobody will be demented to milk, obviously. So, even if it is mild dementia, the score is 0.25. Understood. So, any positivity just gives you a frailty score as positive, right? Because assume if the patient is demented, he is obviously frail. So, in similar way, if he's feeling sad somewhere, elderly patient, he is frail. So, all these, any positivity in this trauma frailty score will give a positive frailty index, and you can call the elderly man frail. Why do we need to do this? Why am I stressing on this so much? Because frailty positivity gives a more mortality index to the patient. So, why do you need to know that? If the patient is frail, you cannot have this bias called too old to benefit. Okay. Age is just a number, they say, but it's not in terms of how young he feels or not. Age is just a number so that you need to individualize your treatment and don't generalize your treatment. You cannot have this bias saying he's too old to benefit. When you have this bias in you, it leads to suboptimal resuscitation. With normal resuscitation, you may never know. Even a 90-year-old man may live up to 100. Okay. If you're doing an optimal resuscitation, don't consider the age as a number and decide he's too old. There's no point in doing much resuscitation. It's a waste of resources. That's not for us to decide, right? If the patient is frail, individualize, right? Do your resuscitation. The patient most likely may respond because the mortality is increasing because of suboptimal resuscitation. The name itself says suboptimal. If you do optimal resuscitation, the mortality really comes down, the graph goes down. All right. All right. This is actually, I don't know if I have to call it a pitfall as such, because it's not talking deep into the matters of resuscitation as such, but you need to recognize this because the future course of the patient depends on whether you are able to recognize an abuse in the elderly. And trust me, it is more common than we think. Once you begin to know that you have to ask or screen for this, then you will be surprised to find out how many patients are actually getting abused. And abuse doesn't only mean physical abuse in the form of lashing them or beating them. It doesn't only mean sexual abuse. It can even mean a neglect, financial abuse, not a medical abuse in the form of not giving them adequate treatment. Yeah. So all these still amount to abuse. And again, my point in telling this is abused individuals still have a higher risk of mortality because their baseline physiological milieu is itself bad, right? So these are some signs of elderly abuse. So I'm just going to read them out. Stops taking part in activities that he or she usually or used to enjoy before. And this, the telltale sign, like if you look at it, you get a red flag for abuse is looks messy. Okay. Elderly patients don't think they look messy normally. They don't. They tend to groom themselves, they take care of themselves. But if they look messy with unwashed hair, dirty clothes, whatever, please think of abuse. Yes, it could be an underlying dementia, but still think of abuse. Have this in the back of your mind. Because asking the simple question or couple of questions will give you the screen positivity for abuse, right? And they have trouble sleeping and they lose weight. Okay, this is not just cancer. If they're losing weight for no reason, nothing else is there, think of abuse because they're not being fed well. Yes, and all other acts of being withdrawn, display signs of emotional trauma. Again, this is another red flag that you cannot miss at all. Okay, if they have unexplained bruises, especially in the genital area or inside of the thighs or the buttocks, with something which is not explained with a routine trauma, right? And burns, cuts and scars, all this, they give an indication towards abuse. And if they have broken eyeglasses, sprains, normally if you're losing eyeglasses, they want to read something. And if they're not getting replaced, what does that mean? They're not being taken care of by their caretakers. Yes. So that is another kind of medical abuse or a neglect from their caretakers. And they have physical signs of punishment, which I just listed here. Yes. And they develop bed sores or other preventable conditions. Yes. Bed sores, plus minus, sometimes rehab patients living in homes, even with adequate care, they may develop bed sores. But just keep it in mind that this could also mean not being taken care of properly. Yes. And lacks medical aids like glasses, like I just explained. They don't have walkers in spite of needing them. They don't have dentures in spite of needing them, hearing aid, no medications in spite of having some comorbidities. That just goes on to say that they are not being taken care of well. Okay. And financial abuse will be known by if they have an eviction notice. I mean, I don't know if you can face that in India, or if they have some financial obligations or commitments that they are unable to meet. Even at that age, you might have to think of a financial abuse on their part. Okay. And if they're not living in safe conditions again. Okay. Well, all these things. So you can just read for yourself. This is not new to you. My point in putting this up here is this will give you an indication to prevent future traumas in a patient. Okay. So this, though it is not a major pitfall, but not recognizing abuse can kind of hamper care in the future also. Okay. And you don't know what to anticipate. Getting probably some help, getting them to a nursing home will aid in future management of the patients. Okay. All right. So let's cycle back to our scenario. Now we have discussed extensively like what pitfalls or what red flags can be missed in an elderly patient. So let's go back to the scenario. It was a 75-year-old man, simple ground level fall in the bathroom, had a blood pressure of 100 over 70, GCS of 7 over 15, and a scalp hematoma, right? Intubation was done. RSI doses of etomidate and succinylcholine given. Post-intubation blood pressure dropped to 60 over 40 and sustained cardiac arrest. What could have been done? Just going to look for any chats. If you have any answers, just drop in the. I think chat is disabled, but it's okay. If you're thinking of these three at least, then fantastic. Okay. Relative hypotension. Yes. Look at the blood pressure. 100 over 70. He's probably a prior hypertensive. I'm not happy with that blood pressure in this elderly gentleman. Optimization before intubation. He should have been given earlier fluids or maybe blood products before giving, before deciding to right away intubate. Yeah. Optimize before intubation using base deficit and lactates as objective signs to see the extent of shock. Okay, we have discussed about occult shock and cryptic shock, haven't we? Yeah? So this is where the patient lies in. He has an occult shock. Okay, so this should have been used and reducing the doses of RSI drugs. Etomidate, if you're using 0.3, maybe 1.5 would have, 0.15 would have been okay in this patient. Okay, succinylcholine, using lesser doses of inducing and paralytic agents, that probably could have prevented an arrest in this case. Okay, GCA of 7 by 15, bad thing, and scalp hematoma. Elderly patients tend to lose a lot of blood in scalp hematoma. So he did lose blood, and he probably is still losing blood. And there was no adequate circulatory resuscitation getting done in this patient, which is why the patient had arrested. Okay. So that is what I meant by optimization before intubation, using base deficits and lactates and using them to guide your circulatory resuscitation. Right. Even now the ATLS guidelines say treat massive exsanguination first. Okay. Please XABCD now. Right. So scalp hematoma in an elderly man is probably massive exsanguination. Okay. So concluding my talk, I just made this image so that you will understand well. You can just take a screenshot of it if you're looking at it. So talking about frailty, what are all the expected changes in an elderly man? If you come to airway and C-spine, the patient may be edentulous. We have discussed this earlier. There are loss of protective reflexes. There can be arthritic changes. Now, if you come to circulation, may have prior cardiac diseases and hypertension. We have seen how they can affect your resuscitation and the vitals of the patient. Okay, and effects of induction agents. They act more. They tend to cause more cardiovascular collapse. Prior medications like beta blockers, anticoagulants, blood thinners, and decreased sensitivity to catecholamines. Okay, that will mask the tachycardia response. Coming to breathing and ventilation, degeneration of spine, kyphoscoliosis, and reduced functional reserve capacity. Okay, functional residual capacity. I'm sorry. FRC is reduced. They have less ciliary motility, so they can't clear out secretions as good as us or younger people. Okay, so this can again predispose them to aspiration, infections, atelectasis, collapse, and all those. And compounded with a rib fracture, let's say, it's bound to go down even further. Okay, coming to disability, right here. There is cerebral atrophy. We have seen how it affects. It can cause SDH, and there are prior existing neurological disorders. Like the patient may already have strokes. Patient may have a Parkinson's disease predisposing them to falls. Patient may have a dementia. So that again will mask your other normal findings. You don't know if there is a baseline reduction in status or if it is new thing. So go ahead, keep a low threshold to image the brain whenever possible. Coming to exposure, we have discussed there is loss of skin elasticity and subcutaneous fat, predisposing them to more hypothermia, and they are often malnourished, again predisposing them to so many, be it bed sores, pressure ulcers, earlier infections, and all those. One important thing, renal. There is reduced GFR and reduced loss of function. And like I said, there can be reduced sensitivity to ADH, antidiuretic hormone. So if the patient has lost blood, ADH is normally released to retain the fluid in the body, yes. But what happens because of that? Patient has lost blood, there is no sensitivity to ADH. So he still keeps filtering out urine. So what happens because of that? Blood loss compounded with normal urine output, gone. Further predisposing to hypovolemia and hemorrhagic shock. Yeah. So coming to musculoskeletal, there is osteoporosis. So you can expect rib fractures, pelvic fractures, all kinds of fractures, even with ground level and trivial traumas. Degenerative changes, loss of lean muscle, again predisposing to hypothermia. So this is how I want to conclude, because this is where you can expect pitfalls. If you extrapolate these physiological changes, you will understand where you can expect pitfalls. And adding on to this, keep in mind a possibility of abuse. So these are my references, and I really thank you for the opportunity and for listening patiently. Open to questions, please. Over to you, Pranay. Thank you so much.
Thank you, Dr. Sharad sir, for taking the inciting topic of pitfalls of geriatric trauma. The session's open for questions.
Says the chat is disabled. Should we enable it?
Okay. Thank you, Sharad sir, for taking a insightful topic on pitfalls of geriatric trauma. You have not only highlighted just the complexities in managing trauma patients, trauma in the elderly patients, but also you have given us an idea of the physiological changes that happens as we age in the natural cycle. Most of these patients have a lot of physiological changes, as well as they are usually on polypharmacy, like they can be on antiplatelets and anticoagulants or beta blockers. So they might not give the same response as you see in a regular adult patient. So as the bottom line for today's topic would be to individualize our resuscitation and always make sure we have the idea, or rather have the basic understanding of the physiological changes that happen in elderly patients in the back of our mind, so that we can give a tailored treatment and tailored plan of care.
Yeah. If I had this on a line, I would probably say elderly patients don't die just because they're old. They die because we underestimate them. We underestimate our resuscitation. Yeah. Exactly.
So we should always tailor our resuscitation to the physiological changes that happen in the elderly, because if there's no one size fits all resuscitation when we come to geriatric population. So if we do the same resuscitation as we do for adults, we may tend to over resuscitate, causing severe problems. Also, most importantly, as sir said, always look for signs of elderly abuse, because There can be not only physical abuse like trivial falls or unexplained like, bruises. It can also be neglect, and only on having a keen sense of vision or keen sense of doubt that patients may have suffered neglect, only then can we treat them better. I would like to thank all our participants for their engagement and questions. Discussions like these will keep us in check with the updated guidelines of how we resuscitate our elderly, and make sure we follow our standard protocol. Before we conclude, I would like to thank the organizing chairperson and the organizing team, and also Yashoda Hospitals for conducting these sessions on a weekly basis. Thank you once again, and we look forward to your participation in our next emergency medicine seminar. Thank you.
Thank you so much.